All right, so a very good evening, everyone. Okay, so just give me a quick reply. So, am I audible and visible to all of you? Yes, just give me a quick thumbs up or quick reply. So, am I audible and visible to all of you? All right, now, yeah. So, let us discuss some of the very important images in the general medicine. So, definitely the images they come around 30 to 40 percentage of questions will be mostly images. So that is the reason why we have started the new sessions called Imageathon, which will be definitely useful for your upcoming NEET PG exam, which is on March 5th. Okay, right. And having said this, now let me tell you immediately after the completion of this particular session, I'll be posting this PDF on my Telegram channel, right? And my Telegram channel is Medicine Made Easy by Dr. Rajesh Gubba, right? So in this particular Telegram channel, I'll be posting this PDF with annotations. So you can join my Telegram channel wherein you can download this PDF. Okay, right. Having said this, now let me just tell you quickly what is just going on Unacademy. So Unacademy has come up with two important batch courses. One is the FMGE Mastery batch, that is mainly for the students who are appearing for the June FMGE exam, and the other important batch course, it is the Aspire Next 2023, right? So that is a 9 months course, and these particular batch courses are with have come up with very subsidized rates. And if you use my code, that is MED10, right, so you will also get 20% discount on this batch courses. Okay, so one is the FMG mastery batch, like that is for 5 months, and the other one is the Aspire Next 23, which is around 8 to 9 months. Okay, right. Now having said this, now let us just move on to the discussion of the images for which we are here right now. Okay, so the first question is, during a neurological examination, you ask a patient to stand with both arms fully extended, parallel to the ground, with eyes closed for 10 seconds. Now, after a while, what has happened is the hand of this particular individual has turned. What is the name of this test? Babinski sign, dysdiadochokinesia, Lhermitte sign, Pronator drift, Romberg sign. Yes, any one of you? Very good. So the answer to this question is the pronator drift. The answer to this question is the pronator drift. Now, what exactly is this pronator drift? Let me tell you. See, the presence of the pronator drift tells you that there is an upper motor neuron lesion, right? Tells you that there is an upper motor neuron lesion. Okay. Now, by if one of the forearm, if it pronates, right, if a forearm pronates with or without downward motion, then the person is said to have pronator drift on that side, reflecting a contralateral pyramidal tract lesion. Now, which particular arm of the individual is undergoing this pronator drift? That is the left arm. Okay, so when the left arm is undergoing pronator drift, now which side the individual pyramidal tract is gone? It is the right pyramidal tract lesion. It is the right pyramidal tract lesion. Okay, so now why does this pronator drift occurs? Let me tell you, in the presence of upper motor neuron lesion, the supinator muscles in the upper limbs are weaker than the pronator muscles, and as a result the arm drift downwards and palm turn towards the floor. Okay, so this is what is your pronator drift. Okay, so please remember, this particular individual is having pathology within the right pyramidal tract, and this is what is your pronator drift. Now, what is this Babinski sign? Babinski sign is also the one which will tell you that there is upper motor neuron lesion, but Babinski sign is the one we will demonstrate within the lower limbs. right? And what about dysdiacokinesia? Dysdiacokinesia is the important examination finding in case of cerebellar lesions. In cerebellar lesions, you have this dysdiacokinesia. Next, Lehermit sign. What is Lehermit sign? That is on flexing the neck, the individual will have electric shock-like sensation down the spine. That is what is called Lehermit sign or Lehermit symptom. And which condition you will get this Lehermit symptom is in patients with multiple sclerosis, in patients with cervical spondylosis, in patients with subacute combined degeneration of spinal cord. In all these conditions, you get this Lehermit symptom or Lehermit sign. Then the next important is Romberg sign. Romberg sign is positive in case of the cerebellar lesions. Okay, right. So this is about the first important image based question. Now you see the next question. Okay, a 30-year-old female presents with complaining of gradual onset weakness of legs for 1 month with reduction in the visual acuity and the urinary incontinence for past few days. Contrast MRI shows the periventricular lesions. So you can see the periventricular lesions here. Now what is the question is, which among the following, right, is not used in these patients? The options are fingolimod, beta interferon, glatiramer acetate, mitotane. Right. So can anyone tell me what exactly is the diagnosis of this image? Yes, what exactly is the diagnosis of this image? Very good. So the diagnosis of this image is the multiple sclerosis. Right. In multiple sclerosis, which among the following drug is not being used is the basic question. Right. So in my very good SNE. So in multiple sclerosis, that periventricular lesions, whatever you are having, that is called as Dawson's fingers. Okay. Now among the options which has been given to you, the one which is not used in multiple sclerosis is the mitotane. So please remember, mitotane is not being used. Whereas the other drugs, Dark Knight and as well as Deepak Patel, the beta interferon is one of the drug which is used in the treatment of the multiple sclerosis. Okay. Okay, you want me to use the yellow highlighter? Huh? Okay, right, fine. So now what are the drugs which we use in the acute episodes of multiple sclerosis? In acute episodes of multiple sclerosis, the drug that we use is the methylprednisolone, right? And if you come out of that acute episodes, we have disease modifying therapy. And within the disease modifying therapy, we have the interferon beta, glatiramer acetate, natalizumab, fingolimod, mitoxantrone, dimethyl fumarate, teriflunomide, alemtuzumab. These are the disease modifying therapy drugs. And the one which we don't use is your mitotane. Now, can anyone tell me in which endocrine disorder the mitotane is being used? Yes, any one of you? In which endocrine disorder the mitotane is being used? Any one of you? So mitotane is that particular drug which is used in the treatment of Cushing's syndrome, right? In Cushing's we use this mitotane. Okay, so this is a very important point, please remember this, right? Next, right, very good SNE. Now we'll move on to the next important image based question. Yes, so these are what is your Dawson's fingers, right, which is nothing but your periventricular plaques which are seen in patients with the multiple sclerosis. And what plaques are these? These are mainly the demyelinating plaques. These are mainly the demyelinating plaques. Okay, now yes, you see the next question, right? So the question is, 54-year-old woman presents to the emergency department complaining a abrupt onset, what she describes as the worst headache of her life. You are concerned about the possibility of the subarachnoid hemorrhage. Now, what is the most appropriate initial test for the diagnosis? First option is your contrast CT, second option is plain CT, then third option is CT angiogram, fourth option is the lumbar puncture. So what do you think is the correct answer in this question? Right, very simple and very easy question. So the answer is the plain CT. Right, the answer is plain CT. Non-contrast CT is what we need to use. Now, what about the role of other investigations in subarachnoid hemorrhage? Let me explain to you. Now, why is that we need to use the plain CT, that is non-contrast CT? That is because in case of subarachnoid hemorrhage, like what you get is, right, what you get is the hyperdense lesions. right? Within the sylvian fissure, you have the hyperdense lesion because of the presence of the blood. So the head CT, that to a plain CT, is most sensitive. Okay, and this head CT or the non-contrast CT, it should be performed immediately after the onset of the symptoms. And as the duration of the onset of symptom increases, the sensitivity of your plain CT also declines. The sensitivity of the plain CT also declines. Now the question is, like, when will you do a lumbar puncture in a case of the when will you do lumbar puncture in a case of subarachnoid hemorrhage? Like, now as the time has passed on, you did not do a CT scan. Now you are suspecting subarachnoid hemorrhage, but the CT scan is negative. The CT scan is negative. Then in such case, we need to do the lumbar puncture. In such case, we need to do lumbar puncture. Like, what happens is, if the lumbar puncture is performed more than 12 hours after the onset of your subarachnoid hemorrhage, right? If the lumbar puncture is being done after 12 hours after the onset of subarachnoid hemorrhage, the red blood cells, they begin to decompose, right? And the RBC, they get mixed with the CSF, and that will result in what is called xanthochromia. A yellow to pink coloration of cerebrospinal fluid will be there. So when your CT scan is negative, then you can do this particular lumbar puncture. Now the question is about the contrast CT. Now, why is that we don't do contrast CT in patients with subarachnoid hemorrhage? See, the head CT with IV contrast is not useful in subarachnoid hemorrhage. Why? Because the brightness of the contrast material may make it difficult to identify the blood in subarachnoid space. That is the reason why contrast CT is not being used. Right? Contrast CT is not being used in case of the subarachnoid hemorrhage. Right? Now, what is the role of the CT angiograph in case of the subarachnoid hemorrhage? CT angiography that is performed with IV contrast can be useful in identifying the aneurysmal vessel, because what is the most common cause of subarachnoid hemorrhage? That is your head trauma. And the second most common cause of subarachnoid hemorrhage is the rupture of berry aneurysm. Now, in order to identify that aneurysmal vessel, then you can do the CT angiograph that is performed with the IV contrast. Now, I'll show you one more important investigation in subarachnoid hemorrhage. Tell me, what is the role of the investigation? Yes, please answer this particular investigation. Why is it being done in case of subarachnoid hemorrhage? Yes, can anyone answer this? Why is this particular investigation being done in subarachnoid hemorrhage? Yes, any one of you? What is the role of this transcranial Doppler? Let me explain you quickly. See, the transcranial Doppler ultrasound is a test that measures the velocity of the blood through the cranial vasculature. Okay, so it is used in some centers following subarachnoid hemorrhage to assess for the development of vasospasm. And whenever there is development of vasospasm, it can worsen the ischemia, leading to increased damage to the brain tissue following subarachnoid hemorrhage. So in order to look for if there is any development of vasospasm, we do the transcranial Doppler. Okay, that is the role of the transcranial Doppler. Okay, right. It is not for looking your berry aneurysm. For looking the berry aneurysm, like what we do is the CT angiography. Okay, right. So that was the image based question related to your the subarachnoid hemorrhage. Now, okay, you try to answer this question. Let me see who can answer this. A 45-year-old is admitted to the emergency department after the first episode of witnessed abnormality shown in the figure. Like, what exactly is the abnormality? This is the abnormality which is shown in the figure. He is administered lorazepam 2 milligrams with cessation of abnormal activity. All of the following are likely possible causes of his abnormality, except the options are alcohol withdrawal, metabolic disorder, brain tumor, genetic disorder, hyperglycemia. Yes. So first of all, please identify the abnormality which is shown in the figure. The abnormality which is shown in the figure is, you can see there is tonic phase, there is clonic phase, and there is the post-ictal confusion state. So what exactly is this? It is nothing but it is an episode of generalized tonic-clonic seizure. Now, the age of the patient is very, very important here. What is the age of the patient? That is 45-year-old man. And at the age of 45 years, he has the first episode of the generalized tonic-clonic seizure. Now, in 45-year alcohol withdrawal, yes, it can happen. Then what about the metabolic disorders? Yes, even there are certain metabolic disorders which can cause the development of generalized tonic-clonic seizures. What are those? Like hyperglycemia, hypoglycemia, uremic encephalopathy, hepatic encephalopathy, electrolyte abnormalities. These are the metabolic disorders that can cause generalized tonic-clonic seizures. Okay. Now hyperglycemia, which clinical condition of hyperglycemia you can have this GTCS? Like you have a very important complication called HONC, hyperosmolar non-ketotic coma, which is very common in type 2 diabetes mellitus. There they can have this generalized tonic-clonic seizures. Now what about the brain tumor? Yes, in an individual of 45-year age group, there can be development of the brain tumor that can cause the generalized tonic-clonic seizure. Now, hyperglycemia, yes, it can cause generalized tonic-clonic seizure, but you take this terminology, the genetic disorder. The genetic disorder, this particular genetic disorder is not coinciding with the age of the patient. Okay, so these genetic disorders typically present in childhood and rarely after the age of 18 years. Now, what are that particular inherited metabolic disorders that can cause seizures? The inherited metabolic disorders that can cause seizure is the phenylketonuria, then maple syrup urine disease, then galactosemia, then Tay-Sachs disease. So these are inherited metabolic conditions that can cause the seizures. Okay, right. So if you miss seeing the age of the patient, then you will miss this particular question, right? Right, yes. So definitely this is one of the silly mistake if you do an incorrect in this particular question, right? So the answer is the genetic disorder, right? Okay. Now we'll move on to, and in case of generalized, okay, with the treatment of GTCS and all, we have some other questions. I'll discuss about them. Right, now you see the next question, very interesting. A 56-year-old man with glioblastoma multiforme in right frontal lobe experiences his first generalized tonic-clonic seizure. What is the best course of the action for this patient? Initial therapy with ethosuximide, initial therapy with lamotrigine, initial therapy with phenytoin, observe for additional seizure and initiate therapy only if additional seizures occur. Fifth option is refer for electroencephalogram and treat only if an epileptogenic focus is identified. Yes, any one of you? Right. No, we Dark Knight, we don't use ethosuximide for generalized tonic-clonic seizures. Ethosuximide is the drug which is used for the treatment of the absent seizures, right? Which is used in the treatment of the absent seizures. Ethosuximide is completely ruled out. No. It is not phenytoin, which is very commonly being used for generalized tonic-clonic seizures in the recent days. Now, currently, there are two important drugs which are used for the generalized tonic-clonic seizures as the initial therapy. One is your lamotrigine, and the other important is the valproic acid. Okay, now there is a confusion between your option B and as well as the option D. See, the although uh, this particular determination of when to initiate the epileptic drug therapy can be difficult in clinical practice given the variability in presentation of seizure disorder and large number of anti-epileptic drug availability. Now, in which group of individuals you need to start the anti-epileptic drug? Number one, anti-epileptic drug should be initiated when an individual presents with either recurrent seizures of unknown etiology or known etiology. So recurrent seizures are there, then definitely start anti-epileptic drug. Second indication for starting anti-epileptic therapy is in individuals with a single seizure and a clear cause such as brain tumor, infection or trauma is there. Even these individuals also have to be initiated with the anti-epileptic drug. Now our patient is having the glioblastoma multiforme. That means it's a tumor. And like one episode, the first episode, so single seizure with a clear cause of brain tumor, it's an indication to start the anti-epileptic drug. So the answer here is the initial therapy with lamotrigine, because the two anti-epileptic drugs, lamotrigine and as well as valproate, these are the two important drugs which are currently used for individuals with generalized tonic-clonic seizures, and ethosuximide is no way used in generalized tonic-clonic seizure because it is a drug which is used in the treatment of absence seizures. Now, what about this particular the phenytoin? See, phenytoin once upon a time, right, when the other new drugs have not I mean, not the new drugs have not been identified, then the phenytoin was being used. But now the first line therapy as phenytoin is no more used. Okay, so the correct answer is B. The correct answer is B. Now, Soumya Gupta, like what is the duration in this individual will be? See, this particular patient is having the brain tumor, right? And it all depends upon how that particular brain tumor is responding to your radiotherapy or chemotherapy, right? And if the tumor is there, definitely you have to give this lamotrigine lifelong. If the tumor is not subsiding, then you have to give this lifelong. Okay, so the answer is B, lifelong. Right, now we'll move on to the next question. Okay, which of the following patients with Parkinson's disease is the best candidate for this procedure? Right, first of all, you should identify what exactly is this procedure. The options are 64-year-old women on levodopa carbidopa therapy who continues to experience episodes of freezing while walking. Second option, 68-year-old man with recurrent falls due to orthostatic hypotension. Third option, 70-year-old women with severe tremor unresponsive to the dopaminergic therapy. Fourth option, 71-year-old man with worsening symptoms of dementia. Right? And fifth option, all of the above patients will respond to deep brain stimulation. So what do you think is the correct answer here? Okay, so what is the procedure here? It is your deep brain stimulation, that is your DBS. Okay, and deep brain stimulation is the most common surgical therapy which is being performed for Parkinson's disease. Now in this surgery, the electrode is placed into the target area. So where exactly is this electrode placed? It is placed in the subthalamic nucleus, right, or the globus pallidus interna, because your substantia nigra is degenerated in Parkinsonism. So the target area will be subthalamic nucleus or globus pallidus pars interna, right? In this you have the electrode. This particular electrode, it is connected to the stimulator. You have a battery which is usually placed in the chest wall. This battery or stimulator is placed in the chest wall. Okay, right. Now what exactly is the precise mechanism by which deep brain stimulation works is not known, but it is thought that to act by disrupting the abnormal signals association with the Parkinson's disease. Now, like once your deep brain stimulation, that electrode is being placed, then you need to adjust many variables like voltage, frequency, pulse duration, everything should be adjusted. Now, what is the prime indication for deep brain stimulation? The prime indication for deep brain stimulation is the severe tremor or levodopa induced motor complications that cannot be controlled with medications. So in this particular scenario, we place the deep brain stimulation. Please remember, your deep brain stimulation does not improve falling, does not improve freezing, does not improve dementia. So the correct answer here is the C. Okay, so please remember, it is only for severe tremors which is not being responsive to your dopaminergic therapy. Okay, right. Now we'll move on to the next important image. Right. So this is okay. If anyone can answer this, I'll be very happy. And definitely I can say it's a little slightly difficult question. But if anyone can if anyone can answer, I'll be very happy. Right. Let me see. And it should not be a fluke answer. Don't tell like A, B, C, D. You should substantiate your answer also. Okay, right. So the question is, or the clinical scenario is, 54-year-old man presents with complaining of weakness. He has a difficult time pinpointing at the onset. Like when was that weakness started? He doesn't know. He believes he first noticed weakness in his right foot and leg about 6 months ago. He reports that he frequently trips over his toes and drags his foot. He also gets frequent cramps when he stretches in bed in the morning. The weakness is progressing to involve both the legs now. On examination, you note tongue fasciculations. Right, you know tongue fasciculations. Deep tendon reflexes 3 plus at the knees and ankles. Strength is 4 minus at extensors and flexors of the right foot and 4 plus at the left foot. Hand grip strength is also 4 plus. What is the site of action of the drug used in this disorder? Now, can anyone tell me first of all what is the diagnosis of this clinical scenario? Right, what is the diagnosis of this clinical scenario? It is not myasthenia gravis. It is not myasthenia gravis. Very good, Sushant. I'm very happy for you. So it is the motor neuron disease. And what type of motor neuron disease is this? It is amyotrophic lateral sclerosis. Right? Now, how will you tell that it is amyotrophic lateral sclerosis? Because in this patient, upper motor neuron signs are there and lower motor neuron signs are also there. Now, what are the upper motor neuron signs? The upper motor neuron signs, let me just circle them with the blue color. The deep tendon reflexes 3 plus, right? That is an upper motor neuron sign. That is exaggerated deep tendon reflexes. Normally, deep tendon reflexes will be only 2 plus. Now, what will be the lower motor neuron symptoms? I'll just circle them with the green color, the lower motor neuron findings. That is the presence of the fasciculations over the tongue. Then tripping of the toes. Why is that? That is because of your peripheral neuropathy. Okay, so this patient is having upper motor neuron and as well as the lower motor neuron signs, which is suggestive of the amyotrophic lateral sclerosis. Now you should know what is the drug which is being used for the treatment of the amyotrophic lateral sclerosis. As such, there is no specific therapy for amyotrophic lateral sclerosis, but there are certain drugs which can reduce the severity of the disease or which can arrest the progression of the disease. Now, can anyone tell me what is that particular drug? That particular drug is Riluzole. That particular drug is Riluzole. Okay. Now, what is the mechanism of action of what is the mechanism of action of Riluzole? First of all, you should know the pathogenesis of the motor neuron disease or amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis, it occurs mainly due to excessive release of excitatory neurotransmitter, that is glutamate. Right, it is due to excessive release of excitatory neurotransmitter, that is glutamate. And why is that excessive release of the neurotransmitter glutamate occurs? That is because of superoxide dismutase 1 transgene mutation. And this glutamate which is being released, that will cause free radical damage of the motor neurons, causing motor neuron disease. Now, what is that we want? We want that glutamate should not be released. Okay, we want that glutamate should not be released, for which we give Riluzole. Now, where will this Riluzole act? This Riluzole will act at presynaptic level. It is not the postsynaptic. It will act at the presynaptic level. So, this Riluzole reduces the presynaptic release of the glutamate by blocking the sodium channels. Right, by blocking the sodium channels which are present on the presynaptic neuron. So that is the reason why the answer will be A. The answer will be A in this question. Okay, so right, definitely I can consider this is one of the difficult question, not a very easy question. First of all, you should identify the diagnosis. Second, you should know what is the drug which is being used. Third, you should know the mechanism of action of the drug. And fourth, you should know on which particular channels this drug act. Is it presynaptic or postsynaptic? Okay, so the answer is A here. That is presynaptic sodium channel blocker, and that will inhibit the glutamate release. Okay, right. So after having discussed about little difficult question, let me move on to little easy question now. Right. Now, okay, so if you see this question here, 58-year-old woman is seen for complaining of very sharp pain that is lasting about 1 minute over her right cheeks and lips. These pain episodes occur in clusters with intense pain during the episode. So they occur in the clusters. When an episode occurs, it is present both day and night and can reoccur over a period of about a week. Paroxysms of pain can be elicited by washing her face. Right. So by now you should be knowing like what is the diagnosis, right? On physical examination, there is no sensory or motor loss in the right face. There are no masses. Touching the right face does bring about an episode of pain for the patient. What is the next best step in the management of this patient? Right. Very good. So very simple and easy question, right? So it is a case of trigeminal neuralgia, and for trigeminal neuralgia, the drug of choice will be carbamazepine. And at this point, you should know what are the other alternative drugs also. See, carbamazepine is definitely the drug of choice, and if carbamazepine is not effective, you need to give oxcarbamazepine. And if the individual is not responding to carbamazepine or oxcarbamazepine, then in such case, you need to give the baclofen and lamotrigine. So those individuals who are refractory or intolerant to carbamazepine and oxcarbamazepine, in them you need to give baclofen and as well as the lamotrigine. Then what is the surgical treatment that you will be doing in patients with trigeminal neuralgia? That is microvascular decompressive procedure or ablative procedures are being done. Microvascular decompressive procedures or ablative procedures, these are the surgical therapies for the treatment of the trigeminal neuralgia. Okay, right. So the correct answer here is A. Okay, now we'll move on to the next question. Right. So IcePack test is due for. IcePack test is due for. So this IcePack test is the one, very good. So it is the one which is used for diagnosing myasthenia gravis. So now on application of IcePack, like in what way that is useful for diagnosis of myasthenia gravis? On application of IcePack, let me tell you, there will be increased neuromuscular transmission. So because of increased neuromuscular transmission, let me tell you that ptosis which was there, that will disappear, and thereby the ptosis will thereby you can diagnose that the patient is having the myasthenia gravis. Okay, right. Now it was a little simple question. Yes, answer this. What will be the visual defect if the site of pathology is at point 2? Right, what is point 2? This is your point 2. Okay, so what will be the visual field abnormality if the defect is at point 2? The options have been given A, B, C, D. Very good, Tushar. So, right. So, like now what is gone here? It is the optic chiasma which is being damaged. And that too within the optic chiasma, which structure of the optic chiasma has been damaged? It is the medial fibers which are being damaged. When the medial fibers are being damaged, the individual will develop bitemporal hemianopia. The individual will develop bitemporal hemianopia, and these bitemporal hemianopias, they are very common in case of your pituitary tumors like your prolactinoma, right? Or in case of acromegaly, that is somatotroph type of pituitary adenoma, there you can have this bitemporal hemianopia, right? Now having discussed about this, okay, now tell me, what is the variant of multiple sclerosis in which there is extensive demyelination of C3 to C6 vertebral segments? Devick's disease, fulminant multiple sclerosis, relapsing remitting multiple sclerosis, secondary progressive multiple sclerosis. Yeah, very good, Sapna. Even your craniopharyngioma also. Craniopharyngioma, it's a tumor which is originating from Rathke's pouch. Even craniopharyngioma can cause bitemporal inferior quadrantanopia. Right? Now, so now what exactly is this? So the variant of multiple sclerosis where there is extensive demyelination of C3 to C6, this we call it as neuromyelitis optica. This we call it as neuromyelitis optica, and this neuromyelitis optica is nothing but your Devick's disease. Now in patients with Devick's disease, like what exactly will be there? There will be optic neuritis. Along with optic neuritis, there will be transverse myelitis which is extending more than or equal to 3 vertebral segments. That is what is your Devick's disease or neuromyelitis optica. Then what about this fulminant multiple sclerosis? Fulminant multiple sclerosis, the another name for this is Marburg disease. right? So in case of fulminant or Marburg disease, there is rapidly progressive and fatal multiple sclerosis, which is associated with severe axonal damage, inflammation, and necrosis of the axons. That is what will happen in case of fulminant multiple sclerosis or Marburg disease. Now, RRMS and as well as SPMS, like I have few more questions to discuss on multiple sclerosis. There I'll show you these images. Okay, right. Now we'll move on to the next. Yes, please diagnose this clinical condition. Third nerve palsy, Addy pupil, Horner syndrome, Argyll-Robertson pupil. Yes, any one of you, please. What do you think is the correct answer? Right, very good, Bembong. Yes, so the answer here is the Horner syndrome. Dark Knight, it is not your Argyll-Robertson pupil, right? So it is Horner syndrome. So like what is all that you are observing here? So the features of the Horners, like what you are having is the ptosis is there and meiosis is there. So these two things you are able to observe. And what are the other features of the Hornets? The other features of the Hornets will be the enophthalmosis, where there is inward movement of the eyeball, right? Then there will be loss of ciliospinal reflex, right? There will be loss of the ciliospinal reflex. Okay, right. Now, yeah, yes, Amulya, what exactly you want? Say the difference between B and D. Okay. Now you take this B. What exactly is your B? That is nothing but your addy pupil. What exactly is your addy pupil? We use the word Holmes addy pupil. We use the terminology called Holmes addy pupil. In case of this addy pupil, where exactly is the site of lesion? The site of lesion is within the ciliary ganglion. For the development of addy pupil, the site of lesion is within the ciliary ganglion. Now, what will be the points in case of addy pupil is there will be dilated pupil. It will be the dilated pupil. Okay, and these individuals with addy pupil, there is also disturbance of accommodation, right? In these patients there will be also disturbance of the accommodation. Okay, right. And how will be the pupil in addy? It is dilated pupil. Now you take this Argyll-Robertson pupil. In Argyll-Robertson pupil you don't have the dilated pupil. What is that you will have in Argyll-Robertson pupil? It is the small irregular pupils, right? It is the small irregular pupils. And even in Argyll-Robertson pupil also there is the accommodation reflex, the accommodation reflex will be present, and there will be absence of the light reflex. That is what you will see in Argyll-Robertson pupil. Okay, right. Yes, Amulya, did you understand this now? In Holmes addy pupil, it's a dilated pupil, whereas in Argyll-Robertson pupil, it's a small irregular pupil. Okay, right. Now we'll move on to the next question. What about third nerve palsy? In third nerve palsy, you can have ptosis, but in third nerve palsy, you will have the dilated pupil. That is what you will have in case of the third nerve palsy, right? Now, so after having discussed about the abnormalities related to the pupil, right? So this is another very important question. So a 58-year male patient with chronic hypertension presented with dysarthria and weakness of the right upper limb. On imaging, what exactly is the diagnosis? Lacunar infarct, then hemorrhagic stroke, MCA stroke, subdural hemorrhage. I'll just zoom this imaging for you. So that history is very important. Chronic hypertension, that history is very, very important here. No, it is not the MCA stroke. No. It is not the MCA stroke. Now, what exactly you are seeing here is the presence of the dotted appearance, right? And this we call it as the speckled pattern, right? And you also have a lacuna. So this speckled dotted pattern, right, very good. So this is what is nothing but the lacunar infarct. Now what is a very, very important point to tell that it is a lacunar infarct? What is the history very important is the presence of the chronic hypertension. right? So in patients with chronic hypertension, like if you have that speckled pattern or dotted appearance within throughout the cerebral cortex in both cerebral hemisphere, that is very much suggestive of the lacunar infarcts. Okay, so what exactly is your lacunar infarct? It is a stroke in a deep area of the brain, right, where the stroke can be within the thalamus or in the basal ganglia or within the pons, right? Okay, now after having discussed about the imaging of lacunar infarct, yes, you see this question. Drug that causes maximum reduction in appearance of new lesion and change in disease severity in the following types of multiple sclerosis: natalizumab, glatiramer acetate, interferon beta 1A, interferon beta 1B. So the question is, the drug that causes maximum reduction in the appearance of new lesion and change in the disease severity is, right, very good, Dr. Amulya. So what exactly is this particular form of multiple sclerosis? That is relapsing remitting multiple sclerosis, that is RRMS. Now in these patients with RRMS, the drug that will cause maximum reduction in expanded disability severity score, right, maximum reduction in expanded disability severity score is natalizumab. And what exactly is your natalizumab? It's a monoclonal antibody which is formed against alpha 4 subunit of beta 1 integrin, right? It is monoclonal antibody which is formed against alpha 4 subunit of the beta 1 integrin. Okay, now what exactly this natalizumab will do? It prevents the lymphocytes from binding to the endothelial cells, and thereby it will reduce the attack rate and it will significantly improve all measures of the disease severity in relapsing remitting multiple sclerosis. Okay, right, so that is about your natalizumab. And okay, one important question is, whenever you are giving natalizumab, what is that particular antibody that you need to test for? Okay, what is that antibody that you need to test for? And only if that antibody is negative, that is when we give this natalizumab, right? Yes, see, almost 1 to 2 percentage. Very good, it is JC virus antibody. Okay, so this natalizumab, it is associated with the development of progressive multifocal leukoencephalopathy in around 1 to 2 percentage of patients, right? So natalizumab is currently recommended for JC antibody negative patients only. JC antibody negative patients only we give this natalizumab. Okay, right, so that was about your RRMS, relapsing remitting multiple sclerosis. Now you take the other patterns of multiple sclerosis. Now if you see this pattern here, what form of multiple sclerosis we call this as? This is nothing but your PPMS. PPMS is what? It is primary progressive multiple sclerosis. Primary progressive multiple sclerosis means there is no acute attacks, but there will be gradual worsening over time. Gradual worsening over time. Yes, Amulya, if JC antibody is being positive, apart from natalizumab, the other drugs that we can prescribe is your interferon beta, or you can also give glatiramer acetate. These are the alternative drugs to your natalizumab, okay, for RRMS. Okay, right. Now the other forms of multiple sclerosis, if you see, right, so this is your SPMS. Now what do you understand by this word SPMS? SPMS is secondary progressive multiple sclerosis. That means initially it will be RRMS and later there will be progression of multiple sclerosis. That is called secondary progressive multiple sclerosis. And this is nothing but your PRMS. What is PRMS? Progressive relapsing multiple sclerosis. That means there will be progression of the disease. Upon progression, there will be, right, there will be even relapses of the episodes. There will be relapses of episodes. Okay, so this is what is your progressive relapsing multiple sclerosis, right? Now after having discussed about the various forms of multiple sclerosis, please answer this. Now you see this image which has been given to you, and please tell me what exactly is the etiology of this following condition: Arnold-Chiari malformation type 1, type 2, type 3, type 4. Right, very good, Tushar. Now, Tushar, can you tell me what exactly is the diagnosis of this image? Yes, what exactly is the diagnosis of this image? Very good, Sushant. So it is Syringomyelia, right? It is Syringomyelia. Now, what is this Syringomyelia? It is a clinical condition where you have the presence of the syrinx. You can see here. This is the syrinx, right? This is the syrinx. Not only that, what is another abnormality that you are seeing here in this image is you can clearly observe that there is herniation of the cerebellar tonsils. Okay, so it is the scenario where there is a herniation of cerebellar tonsils. Along with that, there is syringomyelia. And which condition you come across this? You come across this in Arnold-Chiari malformation type 1. Right? Now this syringomyelia, what is syrinx? It is a fluid filled cyst. And what is the common site for the syringomyelia? That is cervical spine. And this particular syrinx from the cervical spine, it can progress upwards also into the brainstem. Then we call it as the syringobulbia. Now what is a very, very important feature of your syringomyelia? That is dissociative anesthesia. That is a very, very important feature of the syringomyelia. And what will be the distribution of the dissociative anesthesia? That is cape-like distribution. That is there is dissociative sensory loss will be there over the shoulders and as well as the upper limbs. That we call it as the cape-like distribution. Now what are the sensations which are being lost? There will be loss of pain and as well as temperature and even crude touch. And what are the sensations which are being preserved? The dorsal column sensations are being preserved. That is your fine touch, vibration, pressure sense. These posterior column sensations will be preserved in case of the syringomyelia. But spinothalamic tract sensations are being lost. Why? Because in case of syringomyelia, the syrinx will be present exactly in the central part of the cervical spinal cord. And exactly in the central part of the cervical spinal cord, the spinothalamic tracts will be crossing. That will be damaged by your syrinx. That will be damaged by your syrinx. Okay. Right. Now let me just take up the other question. Okay, this is one of the very, very important question in the clinical practice also, not only from the exam point of view, even in the clinical practice, like how you will manage this patient is very, very important. Let me tell you what exactly is the scenario of this patient. So the patient is like a 48-year-old man presents to the emergency department with stupor. Right? What is stupor? It is like near unconsciousness. It is not completely unconsciousness, near unconsciousness. He was feeling well until 30 minutes ago, where he complained of headache and right-sided weakness. He has a history of hypertension and cocaine use. He is prescribed the hydrochlorothiazide 25 milligrams daily, but it is unknown whether he is taking his medication. On presentation, he is drowsy and minimally responsive to questioning. His blood pressure is how much? 242 by 148 millimeters of mercury. Heart rate is 124 beats per minute. Respiratory rate is 24 breaths per minute. Saturation 98% on room air. Temperature 37 degrees centigrade. He is not moving his right arm and leg, and he does withdraw to pain. His non-contrast head CT is shown in the figure. What should be the ideal systolic, right? What should be the ideal systolic blood pressure in this patient? Less than 200, less than 160, less than 180, less than 120. Now, so first of all, you should know what exactly is the diagnosis of this clinical scenario. Diagnosis of this clinical scenario is it's an intracerebral hemorrhage. Right? It is an intracerebral hemorrhage. And this intracerebral hemorrhage is secondary to the hypertension. Secondary to your hypertension. Now, what the question is, ideal systolic blood pressure. How much should be the ideal systolic blood pressure? Okay. So, I'll just show you a table, which is a very, very important table for your exams. Okay. You see here. What is this? It is the current guidelines for blood pressure management in the most common conditions treated in neuro ICU. Now, what is our condition? That is intracerebral hemorrhage. Intracerebral hemorrhage, you need to keep the systolic blood pressure less than 180. But what did I ask you in the question? In the question, I have asked you ideal systolic blood pressure in this patient. The ideal systolic blood pressure in this patient is less than 160 millimeters of mercury. right? There is no harm in keeping the systolic blood pressure less than 180. But how much should be the ideal systolic blood pressure? Less than 160 millimeters of mercury. And mean arterial pressure should be less than 130 millimeters of mercury, right? Definitely, I understand many of you have answered C, but it is not the C which is the correct answer. The correct answer is B. Okay, so let me just correct myself. It is the B. It is not C. So the ideal systolic blood pressure is less than 160 millimeters of mercury. Yes, Amulya, in case of the hemorrhagic stroke secondary to hypertension, sudden decrease is advisable. Sudden decrease is advisable, but again, there is like the sequence. In the first 1 hour, like what you should do, in the first 1 hour, only 20% of your systolic blood pressure should be reduced. But when do I want this ideal systolic blood pressure? I want this ideal systolic blood pressure to be achieved within 24 hours. This ideal systolic blood pressure should be achieved within 24 hours. That is what I want. Okay, right. Now, what about the other scenarios? You see in case of acute ischemic stroke, right? How much is the blood pressure that you need to maintain? If it is prior to receiving intravenous thrombolysis, less than 185 by 110 millimeters of mercury. And if the patient is undergoing thrombolysis, at the time of thrombolysis, just keep the blood pressure less than 180 by 105. And no thrombolysis more than 120 by, more than 220 by 120 millimeters of mercury. In subarachnoid hemorrhage, keep the systolic blood pressure less than 160 millimeters of mercury before aneurysm being treated. And in traumatic brain injury, like the suggested systolic blood pressure will be more than 100 millimeters of mercury if the age of the individual is 50 to 69, or more than 110 millimeters of mercury if the age of the individual is around 15 to 49 years. Okay, so this is a very, very important table for your exams, and based on this particular table, multiple permutations and combinations within the clinical scenarios can be made. This particular table is very, very important. Save this particular table and do a quick revision just before going the exam, and based on this table we can expect a question. Okay, right. Now okay, so this is just a basic integration of medicine and the neuroanatomy. A 28-year male immunocompromised presented with a high-grade fever. Imaging is suggestive of right temporal cerebral abscess, right frontal cerebral abscess, right occipital cerebral abscess, left temporal cerebral abscess. So where exactly is the cerebral abscess being present? Right, so this is the temporal area. And which side temporal area? Right, which side temporal area? It is the right. It is not the left temporal abscess. Okay, just it's a very simple question integrating your anatomy and as well as the general medicine. But what I wanted to tell you is, if the individual is developing the right temporal cerebral abscess or any temporal cerebral abscess, where should be the source of infection? Now, let me show you another very, very important table. Yes. So, if it is the temporal abscess the patient is developing, the source of infection will be from the ear, that is otitis media. The organisms are mainly Streptococcus, Bacteroides and Proteus. And if there is frontal cerebral abscess, the source of infection will be from the frontal sinusitis and the organism is mainly Streptococcus. And if it is cerebellar abscess, again the source of infection is from the ear, that is otitis media. The organisms are same, that is Streptococcus, Bacteroides and Proteus. And if it is parietal cerebral abscess, then the source of infection is embolic. The organisms are same, that is Streptococcus, Bacteroides and Proteus. And any site, like apart from this, if there is abscess, the source of infection could be trauma and the organism is likely the Staphylococcus. Okay. Right. Now, yes, Sushant, in case of the immunocompromised patients, the most common organism that can cause the cerebral abscess could be your tuberculosis. Right? Could be your tuberculosis. Okay. Right. Now, having discussed about the story related to cerebral abscess, now you see the next question. Yes. Following condition is seen in which neurocutaneous syndrome? Neurofibromatosis type 1, neurofibromatosis type 2, Sturge-Weber syndrome, tuberous sclerosis. Right, so very good. So what exactly are these? These are the leash nodules, right? These are the leash nodules. Now, where exactly you see this leash nodules? No, Sapna, it is not neurofibromatosis type 2. It is in the neurofibromatosis type 1. Now, in neurofibromatosis type 1, there are many important images that can be asked. Like you should know the abnormality within the spine in case of neurofibromatosis type 1. That is, the individual will develop scoliosis. And you have a flat pigmented birthmarks in neurofibromatosis type 1. What is that pigmented birthmarks? That will be the CAFU spots. That will be the CAFU spots. And next important abnormal finding within the axilla, right? The next important abnormality within the axilla will be the axillary freckling. That is within the armpits, right? Where you have small circular spots on the skin that are being darker. Okay. And the another important abnormality within the neurofibromatosis type 1 will be the neurofibromas, right? It is a benign nerve sheath tumor in the peripheral nervous system. These are the other important abnormalities. And what exactly are your leash nodules? Leash nodules, they are melanocytic hamartomas that appear as well defined dome shaped elevations projecting on the surface of the iris. Okay, this will be the abnormality within the eye. Right, very good, Tushar. Even there will be development of the sphenoid dysplasia as well. Even there will be development of the sphenoid dysplasia as well, right? And yeah, so these are the abnormalities that you will come across in patients with the uh, neurofibromatosis type 1. Now, apart from this, yes, one of the other option like what you are having is the tuberous sclerosis. In tuberous sclerosis, like what you have is the presence of the hypopigmented macules. You have the presence of the hypopigmented macules. Okay, right. Yes, Amulya, you are asking me the mnemonic for the criteria of remembering the neurofibromatosis type 1. The mnemonic for neurofibromatosis type 1, it is the cave spot. Because you are having these CAFU spots, just remember the cave spot. What is this cave spot? C stands for CAFU spots, A stands for axillary or inguinal freckling, F stands for fibroma, E stands for eye abnormality, that is leash nodules, S stands for skeletal abnormality within the bone where there is scoliosis or even there is sphenoid dysplasia, and P stands for positive family history. OT stands for the optic tumor, that is glioma. Even gliomas are very common in case of the neurofibromatosis type 1. Okay, so this is about your CAFU spots, right? Next, then, okay, last question, right? Last question. So this particular patient, if you see, he is a 18-year male patient presented with severe headache and seizures. Imaging is suggestive of hydrocephalus, right? The primary management has been done in this patient, right? The initial treatment has been done, but now the patient is asking you, or the patient attendants are asking you, what is the drug which can prevent the recurrence of development of hydrocephalus? Mannitol, furosemide, acetazolamide, then thiazides. Very good. So that is your acetazolamide. That is acetazolamide. Okay. So acetazolamide, that will help in preventing the recurrence, which is nothing but a carbonic anhydrase inhibitor. Then how do you treat this particular the hydrocephalus? Like you need to do the lumbar puncture, right? Withdrawal of the CSF. That is mainly to obtain the normal pressure. It is often successful, but the only thing is this may need a repeated number of times. That lumbar puncture, whatever you're doing, right, you need to do repeated number of times. And the another important treatment in hydrocephalus is you need to prevent the precipitating factor. Any precipitating medication is there, that should be withdrawn. Now, what is that precipitating medication that can cause the hydrocephalus is mainly that particular age group, 18 years. Inhalation of heroin, inhalation of the heroin, Okay, that can cause the development of hydrocephalus. And the other poisoning is methadone poisoning and inhalation of the heroin, they can precipitate the formation of the hydrocephalus. And what are all the treatment options? Yes, one is your ventriculoperitoneal shunt, and the other important treatment options are like optic nerve sheath fenestrations. Whenever there is like chronic papilledema developing because of raised intracranial pressure, you can do optic nerve sheath fenestration. Optic nerve sheath fenestration. Okay, so this is about the important images that are being expected in the upcoming NEET PG exam. So mainly I have discussed the images related to neurology. Mainly I have discussed related to neurology. And this particular PDF with annotations, I will send it to you on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. Right. So if you want any other particular sessions, particularly in general medicine, you can text me on my Telegram handle. Definitely I'll take those sessions. Okay. So and yes, thank you very much and see you in the upcoming sessions. Yes, Amulya.